So the math for the modern physical therapist is no longer working. Between stagnant reimbursement rates, skyrocketing productivity demands, and the constant pressure to treat patients like widgets on an assembly line, the profession is facing a viability crisis that hard work alone cannot fix. But what if the solution isn't just advocating for more? What if it requires a total reimagining of where our value actually lives? Today, we're joined by someone who has spent 20 years at the intersection of orthopedic surgery and value based care. Dr. Eric Makhni is a sports medicine surgeon at Henry Ford Health and the co-founder of Protera Health. He has seen the system from the operating room to the boardroom, and he's here to deliver a message that is both a warning and a massive opportunity for the profession. In this conversation, we're pulling back the curtain on the healthcare factory in air quotes. We discuss why the traditional fee-for-service model is functionally dead and why the biggest threat to your career isn't digital health, it's the belief that your value is in your hands rather than your brain. Dr. Makhni shares a powerful clinical vignette on how PROMs can actually prevent unnecessary surgeries. And he clarifies the often misunderstood reality of who actually bears financial risk in the U.S. health system. If you think you're just a provider in an insurance network, this episode will change how you view your role in the value chain. So if you're a clinic owner looking for a way out of the volume trap, or you're a therapist wondering how you fit into the future of MSK care, this is the masterclass in the economics of our profession. Let's dive into episode 22 with our second physician guest, Dr. Eric Makhni.
Absolutely.
Hello, everybody. Welcome back for episode 22 of Future Proof PT. We have our second physician guest. We are so happy to welcome Dr. Eric Makhni. He is here from Protera Health, and we can't wait to have him tell you a little bit about what he does, bullishness on digital health tech and on working with physical therapists, and what a great opportunity this moment in time is if PTs are aware of it. We'd love for you to tell us a little bit about yourself and what you want our audience to know about you.
Absolutely. So, Dana and Alex, super excited to be on the podcast. And obviously, you've seen a bunch of them that you guys have put together. And you guys have both shared your wisdom on ours. So really excited to participate. So in brief, I'm a sports medicine surgeon. I'm at the Henry Ford Health System, so I'm still part-time clinical. And Henry Ford is an integrated delivery network in Southeast Michigan. And coming out of training, I was really excited to get my first job there now about 10 years ago because the system was doing so many cool things in value-based care. They have their own health plan. We have our own health plan, I should say, ACO, different value-based models, very progressive orthopedic department, now a service line. And I went there not knowing exactly what doors are going to open and what I'm going to do, but I just knew there was a bunch of doors there. So before coming to Henry Ford, I had started doing research in patient-reported outcome measures and cost-effectiveness research really since 2007. I've been looking at value-based care and orthopedics almost 20 years now. So it's just really exciting to come to a system that is aligned on those value-based care principles. And, I came to Henry Ford as a clinician scholar. So I had some protected time for research, and that's really what I was focused on. And then we started to implement PROMs throughout the enterprise. And that's where we started seeing the value of that tool and turning it into really a patient care initiative. And then one thing led to another, and we were doing multidisciplinary care programs, bundle payments, quality initiatives, all through the orthopedic service line and at the enterprise level. And what we had discovered was that PROMs and holistic care models are really effective in caring for MSK conditions, especially the degenerative conditions, the chronic conditions, folks with anxiety, depression, obesity, pain catastrophizing. But we were having trouble scaling those models. And we had great results, but we just could not get enough patients into our clinics. And that is what led to the birth of Protera Health. My brother, the former chief of spine at the Brigham and Women's, he was doing the same thing at Harvard and doing multidisciplinary models in back pain. And we kind of said, why don't we just work on this together? And that's how it started. So we spun out Protera Health from our innovations office at Henry Ford as an independent company. And it's been a very, very fun ride since we started.
I'm so happy that you are part of this process. And I think everything you have done already and everything you're trying to do is pretty exemplary. And so even before anything else, I think your efforts resonate based on how much attention you're getting. And part of it is just your understanding of the actual need and how far behind we are are as a country in terms of healthcare. The way we consume healthcare, the way we provide healthcare, and the way we pay for healthcare is backwards. And so it's pretty cool that you were here. Thank you for your time.
Well, no, I appreciate it. And I appreciate both of your guys' educational contribution. That's how I got to meet both of you. I think I reached out to both of you guys because I read what you were writing. And so, I think it underscores that there's a huge opportunity in the space. We'll probably get to this later. There's so many different innovation partners and companies in the space, and we're still probably impacting 1% of all patients. It's probably astounding to think about that most people still do not have access to any of these sorts of cutting edge treatments, and most are being cared for in the old fashioned way.
Can you tell us a little bit about what Protera does and how it's differentiated? I think like a lot of PTs are familiar with the hinge and sword models. Why don't you tell us about your model specifically for those who don't know what it is and why you think it's better than the other ones that are out there?
Yeah. So, as you mentioned, there's all kinds of different solutions. And I would say that I don't even know if I would go far as say one's better than the other. I mean, I think you can look at the data, and then if you have two solutions of the same type, you can look at the data on outcomes and costs and then make that determination. But if you look at let's say the digital treatment space in MSK, you have, we call them like the big box. You mentioned Hinge and Sword, venture backed, super high growth scale and 80% margins, right? These are tech solutions. And the founders of those companies will also unequivocally say they are tech solutions. And I think if you're a Target or a Walmart and you need some sort of exercise solution for your hundreds of thousands of employees across the globe, having a company like our Hinge or Sword actually makes a lot of sense. You can turn it on and it's a tech solution. It's like, I mean, it's basically like a SaaS, but it's on a usage basis.
Mm-hmm.
It is not a clinical solution. And I think that, it's when you are looking at actual cost savings, that's not the most efficient way to lower costs because it's not really proven yet to lower costs at scale. Where Protera comes in is that this is a clinical solution that is made scalable through technology. So we are a kind of holistic, physician-led, and PT-centered model. And the care really exemplifies the concept of the integrated practice unit, which I know we've all talked about too, whereas you're treating the patient, you're treating the person from all angles. That may be clinical. So maybe they need medication, they need an MRI, they need a diagnosis, they might need a surgery. Could be exercise-based from a physical therapy perspective. It could be nutrition-based, inflammation, impact on the diet, weight loss, or it could be education-based. Like, yes, I have knee arthritis. It will get worse sometimes. And I do not need to rush to the ER every time it flares up. I just need to rest and ice it down. And there's also a whole point of pain coping. And in your field, it's, kinesiophobia, people that, that don't know that they can move a painful shoulder and it's okay. It's not going to explode and like they're not going to die if they move their shoulder and it hurts. That every person's different. And I think that when you look at a program like ours at Protera Health, the unique thing is that our founding team, there's 5 of us on the founding team. All 5 of us have MBAs, 4 from Harvard, 1 from WashU. 4 of us are physician leaders that have done this before. So we sit at the intersection of technology, clinical innovation, clinical delivery, value-based care, managed care, and we've all done this before. We've innovated, done transformation, and I think the biggest difference from our program is that our team can use that as a starting point and continue to evolve. Taking a step back, Protera is one of those very few clinical models that we're delivering real clinical care. And as my brother Mel likes to say, we're solving clinical problems with a clinical solution and not solving clinical problems with a technology solution. And I think that's the fundamental difference. And that's why when you see our outcomes, we have a few big studies coming out that are going to be pretty paradigm shifting on cost of care reduction. That's how you can drive those outcomes when you're treating that patient first and foremost on what they need, not just hey, you've got back pain, let's start the back pain approach.
Yeah. And so I think that starting with a diagnosis-based approach is very nearsighted just because there's very few patients fit that model of single diagnosis, single morbidity, right? Like there's multiple comorbidities that are impacting it. And then health consumption is rarely based on the actual clinical need and more based on clinical availability. I think in terms of being a clinician leader who understands business, as well as being a businessman who understands clinical care, important artifact, being on the intersection of developing a viable clinical model that can generate revenue but also generating revenue, providing a viable, concordant treatment is the key. And I think that's where you guys are doing a really good job. And in return, the pushback you usually get from a legacy providers that I know better, if you look at the actual care coordinates on a PT side, it's something like 43% of PTs actually adhere to best practices. And I'm not sure what the physician model is, but I'm pretty confident that it's not going to be too much higher. Or availability, if you have OR time on Tuesday, there's still a high probability of not always following the concordant treatment, right? So I think there's so much opportunity on that. I want to ask you a question, like just from your introduction, and I know you mentioned the outcome measures, right? And it's always been a personal sore spot for me, where I think we have this brilliant tool that provides at least kind of the insight into this individual's suffering and pain impact that we are vastly underutilizing, because even the organizations that are using it effectively, or I should say who are collecting it effectively, are still not using it effectively because they're only using it for compliance reasons. They're not using it as a treatment prognostication. So how do you at Protera Health, and how do you as a clinician, as a physician, use outcome measures to actually impact your care delivery on a digital side, but also on a legacy side?
Great question, Alex. And so, in thinking about proms, this was, I think I'd say 2018. I had a female patient. She was a physical therapy assistant, actually. I was her third opinion for her shoulder. She had a very badly torn rotator cuff, fairly chronic, and she was maybe 63. Kind of that borderline, would you do a shoulder replacement or a repair? And she desperately wanted to avoid a replacement. So we tried to repair it. She knew that there was a fairly high chance that it wouldn't hold up. We repaired the shoulder. She came back in at the 3-month visit, I believe. And we had a little bit of concerns. We got an ultrasound just because she had a little bit of pain, residual pain at the 6-week visit. I can't remember the details, but it showed that the repair did not hold up. Okay. So what I would have normally done, or what many surgeons would have done, was say, okay, your rotator cuff didn't heal. We got to start thinking about a shoulder replacement. We had started to collect proms in a very manual way at that time. What I found at that visit was that her pain scores had plummeted and her function scores had improved by 2 standard deviations. She was a normal functioning patient, and her shoulder was significantly better than it was before, regardless of the rotator cuff at all. And so instead of talking about a shoulder replacement, we said, you're doing great. Let's just see you back in whatever the next 3 months are. Let's see how things go. I saw her again 3 years later for her other side. Her proms were normal. She never got that first side taken care of again. She did fine. So I think what the light bulb went off was that proms are for shared decision making, and you hit the nail on the head. When you collect proms preoperatively after you've already made the decision, it's for compliance, registry, research, reporting purposes. It's not for shared decision making. You have to have the proms in front of you when you make the decision, and teach the patient too. So that was what we did at Henry Ford. We implemented proms at scale, and we had our primary care sports doc saying, we're not referring some of these patients for surgery because their proms are normal and they have a meniscus tear that doesn't need surgery. And so now we're operating on the right people, and we're avoiding really bad, very predictable outcomes when you operate on the wrong person. So I think that's shaped our mindset. And so if you look at what happened at Protera, our whole team, from C-suite across the continuum, clinicians, physicians, physical therapists, dietitians, coaches, our care team outreach, our receptionists, we know what proms are, we know the importance of them, and we educate our patients on them. And so I think it creates this culture of, hey, listen, we're going to use the tools available for shared decision making. And the MRI is fine, the X-ray is important, all that stuff, but we need to know what your physical health is, your pain health, and your mental health. And the best example is, let's say you've got, Uncle Jim. Uncle Jim's got back pain. He's a Medicare member. He comes in, but his pain catastrophizing, his anxiety, his depression levels are totally normal, but he's got low back pain. Then you've got Uncle Joe, same, functional impairment, but has rip-roaring anxiety, depression, pain catastrophizing. Those are 2 different people. You cannot treat them the same. You have to give them different exercises, different counseling, different education. And when you look at, why the big box programs are going to have trouble in some of these populations, like Medicare, for example, or any complex patient population, like if you don't measure those scores and individualize a treatment to those scores, or at least use them as a guide, you will not be able to take care of that patient. That you'll lose them. And I think that's what we're seeing. When you look at some of the differences in a big box program, like I'm standing before you right now, and let's say my weight goes up and down, and when it goes up, my back starts hurting. If you give me an option for a digital program, like an app or an exercise, tablet, widget, I'll use it. But I never would have gone to the hospital for my back pain. And so the question is, where we're trying to do is, yes, we want to take care of the casual pain, but really, what about that 20% that's driving 80% of the costs? Who's taking care of them? You're talking about ERs. You're talking about ASC injections for their back that have no reason to be done ever, and they just keep coming back every 3 months. They have MRIs for no reason, hospitalizations for no reason, pain management, opioids for no reason, surgeries for no reason. That's what we're trying to take care of as well, and that's how you kind of lower the cost curve.
Isn't that amazing? With so much opportunity, the people that can benefit the best and most from access to these solutions are also the people that not always are using them extensively. My other question is just in that same realm, where digital health has an immense opportunity to democratize access to healthcare. And both from the standpoint of cost, availability, as well as accessibility. And yet there's still this a dichotomized approach to traditional care, in-person care versus digital care. And digital care is either being sold as a use this until you can actually get real care, or digital health becomes something of an outlier. But no one understands that digital health as a viable solution, not just a front door, but as a viable continuity of care or continuum of care. So what are you guys doing to promote digital entry point and digital first model to a traditional healthcare consumer who is indoctrinated to believing that I have to see my doctor first before I get to anything else?
Yeah, it's a great question. And look, there's, I think one misnomer is that we need to rely on physicians or clinicians to refer into a program like Protera. The reality is, once you're in the office already, the bias for that physician or that physical therapist is to do in-person care for the most part. And some very famous health systems we've been engaged with, we've had folks on the physical therapy side and the clinician side, but even physical therapists say, what are you talking about? I've got to put my hands on the patient, which of course is not correct, because the whole point of physical therapy is to educate and help patients become self-reliant, because you are not doing house calls 5 times a week to help them with their home exercise program, right? So I think that if you look at the data, 80 to 90% of orthopedic conditions can be managed by a primary care physician, and 80 to 90% can be managed not only with physical therapy, but with digital care. And so there's a lot of that education component. What we're finding is that there's a whole population, maybe 20% of typical population or more, that just can't access in-person care. If Uncle Joe is living in a farm 40 miles out of the city, how is he going to do physical therapy or get to see a clinician? My brother was telling me he was talking to a health plan exec from Hawaii. And if you are on the Big Island and you need to see a back specialist, you have to fly to Honolulu to see a consult, right? And that's what we're dealing with. And not only are there rural access deserts, but urban, right? Like we're in downtown Detroit. I can tell you not everybody can access care very easily or go to physical therapy 3 times a week or see a clinician. So I think that's where the opportunity is. And we studied this at Bellin when we rolled out. We found that the fee-for-service volume actually did not change for the system, because we're taking care of their at-risk population for the employee side. There's still other fee-for-service modalities coming in. So as a provider, you can actually have eat your cake and have it too, where you can say, okay, we'll take care of our value-based population in one way with these innovative programs and still be able to have a very successful fee-for-service population as well. But it's a lot of education, a lot of rewiring, and it's going to the patient directly. We're not going to orthopedic surgeons and trying to change their minds. We're not going to physical therapists saying, give up your volume and send them to a digital program. We are going to those value-based organizations that are already doing population health initiatives and say, look, you're already doing population health for mental health, for weight loss, for care management, post-acute planning. This is just another way to do it for MSK, which is 40% of your MA population.
Eric, I think what I keep hearing is, or what I want to translate for therapists is, there are so many different ways to care for patients well, that therapists should be open to these various integrated care delivery models, remote first, digital extensions, and that really what we're doing when we have those various modalities is we're giving access to as many people as possible. And we know, to your point about just that 120% number, so many folks are just not accessing any sort of MSK care. And these solutions give that access. So the more we can bring an understanding of how these models work, I think we're really doing a service to the therapy community. Alex and I are trying to share this message that therapists have a tremendous amount of opportunity to do different things in their career, but they have to know what's available and then believe that it's good. It's one thing to hear people talk about it, but I think those examples you gave as little mini case studies are great and we need to hear more of them. Like, how exactly can these types of different interventions and different styles and different folks being involved lead to more people getting touched in the right ways by the medical system so that outcomes improve and we change the population's health?
Yeah, and it's interesting if you look at physical therapy and orthopedic care, you lump it in. What there's a place for the in person. There's a place for the specialist. Then there's a place for the this kind of these new models. And if I'm a physical therapist, right? So if I'm a physical therapist, and I have a lot of PT friends. Some love the in-person clinic, that social aspect, just like we like clinic too. But they also, it's a very taxing day, right? The reimbursement, now that I've gotten into this kind of behind the scenes, the reimbursement for physical therapy is not viable at
It's
all.
unviable.
It's not
Thank
viable.
you for saying that
It is not
unprompted.
viable. It is not viable. It is, and it requires tripling up, quadrupling up patients in a session where you're doing modality, and all that stuff is important, but you could not do, I've had some folks say, well, because you're virtual, you don't have the overhead, so you must have tons of profit. The flip side is also the same from a fee for service perspective, because when you're doing a telehealth visit, it's 1-to-1. You cannot have somebody on the stim or the ice or the whatever with a PTA. It is 1-to-1. So even if you do 1-to-1 fee for service care or one to a few in a in-person, the rates are not viable for traditional. And then, it's for a different time. The access model, all that stuff we were talking about earlier before we started the podcast is trying to mitigate, trying to course correct to allow some of these digital modalities to survive in the fee for service world, but they just don't. And so, even for us at Protera Health and every digital solution, we're going to the risk-bearing organization directly because they have the opportunity to save, to actually benefit from those savings, right? A traditional fee-for-service carrier, there's no value-based contracting, so you could save tons of money per patient, but you cannot get paid to do the work that's needed. And if you look at what we do at Protera, 1/3 of what we do would be considered under the billable encounter system. 2/3 of what we do are not. The care team huddles, the navigation, the care coordination, the education, the accountability reminders, the customization of your exercise program. We had a patient earlier this month that was trying to get into aqua therapy as a kind of an adjunct, but couldn't find it. So our health coaches found her an aqua therapy place for her, as like a gym membership. It's not,
Love
you
it.
can't bill for that, right? And so you get the people they need. And I think that the government's trying to get there. And so I think the momentum's certainly in the right place. But yeah, I think if I'm talking to a physical therapist now, the question is, from a job perspective, there is an opportunity now. There's a whole growing opportunity to provide real clinical care, but in a digital format from the comfort of your home, right? You don't need to do a 10-hour shift and then have your notes at the end. You can chunk up your shifts and do some morning, some afternoon, nights, weekends, whatever it is, because there's a huge opportunity to change how you are working. I think that's the big opportunity for physical therapists, that they don't have to be grinding away at a clinic, although we need that too. We need that in-person component too.
Yeah, so I think there's a couple of different caveats here, and one of them is during 2020. So when Chicago closed down, most clinics lost 50 to 75% of their patient volume within a month, and it just goes to show you, right? Like when things turn bad, people refuse to come into a real clinic. Except my clinics retained 80% of the patient volume because we quickly transitioned to telehealth. So we partnered with PhysiTrack, we partnered with a different system, and the biggest barrier to that transition was actually convincing the clinicians that I worked with, that my staff, that your best product is not your hands. Your best product is your knowledge base, your skill set, your ability to identify barriers to recovery, and then creating a right program for those barriers to be addressed. But that took coaching where the clinicians had to understand that what substantiates you as a professional is not your ability to perform care, it's your ability to differentiate care. And that is the difference between someone who's a skilled laborer and somebody who's an expert. And physical therapists are experts in movement, except that there's a slow churn to this redundancy that I have to touch patients, I have to hold hands. Now, and explaining that is a lot more of a customer service. So it's good business development. It's really not not clinical care. Clinical care is substantiated through your knowledge and appreciation of clinical experience, whatever the barriers are, the domain-specific barriers that you can then channel and overcome and educate, right? Educate patients and connect with patients. And the connection can be formed digitally. A connection can be formed asynchronously as long as you know what the needs are. But as long as there's an alignment between a consumer and a provider, a consumer needs to know that their hand may not be held when they're consuming care through a digital system. And the consumer needs to know that the care they receive is going to be structured with greatest concordance to clinical practice guidelines or whatever else you do. And away from this, forgive my language, shooting the shit for an hour in a clinic while I watch you ride a bicycle, right? Like, that's fine, but that's not care. 1% substance, 49% bullshit. Like, you can do 51% substance as long as the 49% are like a non-substantiated, like your customer service experience. So yeah, digital system is that. And yet, the caveat is, I like you, I'm still seeing patients. So I'm in a clinic, and I had this discussion yesterday with clinicians that are like, they're all fellowship trained clinicians. They're all like top of the licensed clinicians, but they just can't understand that you don't need to hold somebody's hand. Your value is not spending 55 minutes with a patient. That's a nice bonus, but that's not a clinical bonus. Your value can be pretty much compressed into a 5-minute session where you identify that barrier from prompts, demographics, from prior consumption history, right? It's all of these narratives that you can collect before so that you can identify, look, you're a heavy consumer of healthcare. Chances are you're going to continue to be a heavy consumer of healthcare. Or you're a catastrophizer. You have this personality that leads you to consume healthcare at a greater rate because you are a little bit more neurotic in your personality, right? Like that personality model, which, like the oceans, right? Like, where are you in the oceans spectrum? So it would be interesting for me to know, how are you guys dealing with this consumer base in terms of identifying someone who's actually not a right consumer of Protera Health, and what are your steps behind it?
So just one quick backtrack on the telehealth side. So I think there's a distinction before, right before I jump into that consumer selection part, is that there's telehealth and there's digital health.
Mm-hmm.
Telehealth is when I'm in clinic and at 1:30 p.m., Joe Schmo has a little film icon on my Epic and I got to go log in. I got to go deliver my care through telehealth. Digital health is comprised of telehealth, but it also has, oh, hey, Joe Schmo has a diagnosis or has a high PHQ-2 score. He's got depression. Joe Schmo now has a video in his inbox about how to do physical therapy when you don't feel motivated. Or, Alice, whoever has high anxiety, how do you do physical therapy when you're scared of getting worse symptoms? That's digital health, right? You can track your logins. You can track your exercises. And so when we talk to a health system, and again, we mostly deal with health plans, but some health systems will say, we already do digital health. We've got Epic and we have, that's telehealth. It's not digital health, because in Epic or any EMR, we don't have a dashboard of people that missed their appointment that we got to call. We don't have a dashboard of who's not trending the right direction for their scores, what videos we can assign them. That's a whole different experience. And then, you had asked Alex about this kind of, I think if I understand your question correctly, is like, how do you educate the patient about this program? How do you get the right people in, right, to the program? So if you look, so we just did a video on this that I can send you guys as well if you want to link to it. So
Yeah.
it's the process of intentional friction. So there's a couple ways we do it. And with some digital health solutions, they will start invoicing the client or the partner or the customer at quote activation, meaning I was curious about something. I signed up for my employer, my health plan. Now I get sent a kit and the plan is now charged. So what that's like is if you go to Amazon and you're curious about a printer and you click and compare a printer and Amazon says, you've now activated, we're sending you the printer and we're charging you, right? That is not actually engaging, right? And so some of these solutions will actually start charging at quote activation before anything's been done. And it's really, what we find is a lot of people are just curious. They start the sign up process because they're just curious. What we do is we are doing some education through the sign up process, but we're inducing intentional friction. Because we're aligned with the plan and we want to do cost savings, we're not a benefit. We are literally a cost saving value-based solution. That is what we're doing. So if we enroll everybody that has interest, it will maximize our revenue, but it will minimize our cost savings. And that is not aligned with the plan. What's aligned with the plan is that we induce intentional friction so that we actually make you jump through hoops and hurdles to get to start our program. Not only are we actually not spamming the entire population. We're looking at diagnosis codes, we're looking at procedure codes in the claim to say, okay, who is actually dealing with symptoms? Who's actually actively having an issue? Then we do a qualification process, and you have to fill out our proms, which is friction. And then you've got to do an orientation. We're not charging any money for any of that. We're collecting all this data for the plan. We're not charging anything. We are qualifying the right person. And once you get through the funnel and you have your question answered, then you meet with the clinician for your first visit. So I think the way we've answered that is that we actually don't need to see you if you, A, are not bought into the opportunity for digital care, or B, don't need us. If you got low-grade symptoms, if you're just casual, if you're just curious, or if you're fine, you don't need to see us. And so I think that's a big distinction. And that allows you, again, to get close to that 20% driving the 80% of costs.
Eric, before we move on, if you could explain to the audience a little bit about how that works. Like you talked about the value-based solution and aligning, and I think like therapists hear those terms and they don't really know what they mean. So not like secret sauce, but what generally does it mean to say we are aligned with the plan where you're both benefiting from it and the patient is benefiting from it, having that triple alignment?
I think to answer that, I will go back in time. 3 or 4 years ago, I had a dinner with the health plan CMO, Chief Medical Officer. I asked the CMO, I said, we're doing this great work in value-based care. We're saving a bunch of costs. Don't you, isn't this of excitement to you? And he said to me something I'll never forget. He said, we've delegated most of our risk out, meaning the insurance company is not really on the hook financially for what happens. And as an orthopedic surgeon at that time with over 10 years of value-based care experience, 15 years actually almost at that point, I did not realize that distinction, that half of our country, their healthcare is through their employer, meaning that if you do an unnecessary surgery and it costs $50,000, the insurance company doesn't really get impacted. Actually, they make money. They get a processing fee. It's the employer who loses the money. And so when we think about educating providers, if you ask 100 orthopedic surgeons on the street or 100 physical therapists on the street, the relationship between an insurance carrier and a patient, they're going to say, well, the insurance company just wants to hold all those payments back. No, it's not the insurance company necessarily. It's actually the employer that's on the hook for 50% of our lives. And we don't understand that. And so there's this blanket us versus them from the provider side and the insurance carrier side. On this journey, I've met with over 100 health plans at this point and CMOs. There are a lot of really, really good, thoughtful, mission-oriented health plan leadership out there. But I think as providers, we don't understand that nuance that the health plan maybe just be acting as a broker, or we call it ASO. And so I think the first thing to educate the physical therapists on, the clinicians on, is that the risk, the financial risk, is held by one of a few places. It could be the employer. It could be the government. Think of a state Medicaid or federal, Medicare plan. It could be a commercial entity like an insurance plan. It could be the patient if they're uninsured. And if they have a big cost share, they have some of that, right? So I think when we say value-based, what we're trying to do is improve the outcomes of the care while decreasing the cost of the care to whoever is at risk.
At risk.
And I think that's the main thing to remember. When we say we're aligned, if you're a benefit, right, your duty is to provide something that is nice to have to that population, whether it's an employee population or health plan population, as a benefit. It is a benefit. It's a perk. Like I work at, Acme Construction, and they give a benefit for, Lifetime Fitness. I get access to that fitness, and this is a HR retention, check the box, but there's value to it. When we say we're aligned with the risk-bearing organization, we are aligned meaning that we've got to drive up outcomes and drive down costs. Actually, revenue maximization is not our initial goal. Obviously, we're a business. We need to make revenue. But really, what's most important to us is saying, can we meaningfully lower the cost of care while improving outcomes? You need some sort of scale to do that. If I engage one patient in a health plan and we save money, that's great, but the plan doesn't benefit, right? Or the carrier doesn't benefit. You need to do at scale. So the revenue the volume takes care of itself, but we need to find the right people and not just, try to maximize our fees. And I don't know if that answered your question or answered that question, but that's kind of the behind the nomenclature.
I think that therapists have a hard time wrapping their head around organizations benefiting and that not harming them, right? So it's easy to demonize, for example, a plan or risk-bearing entity of some kind. But to understand that if you're trying to help the risk-bearing entity, they're responsible for a pot of money. You're trying to do the right intervention so that the high cost interventions don't end up happening. And that involves selecting the right patients. And then the patients benefit that you touch, you benefit. Someone has to not benefit. And the not benefit is whoever would have seen those patients for higher cost procedures. That money is coming from somewhere, but it's not bad for patients, and you can get really good or better outcomes. It's good for you as providing that service, and it's good for the organization that's responsible for those dollars. That's what alignment means. And I think there's 10 different ways to say that message, but it bears repeating as much as we can, because we need provider buy-in of all kinds of providers to keep moving value-based care forward. So I really appreciate you
Yeah.
explaining that to
So
And,
everybody.
and go ahead, Alex.
sorry guys, can I just be the devil's advocate, or to
Please.
give the straw man or the steel man argument? You judge for where we are and where we need to be. U.S. health expenditure is $5.3 trillion. Year-to-year growth in health expenditure is 8%. And then we spend about 18% of our GDP on healthcare in the United States as of 2024. Value-based care has been around for, 15 years, more or less, since conception. Why has value-based care not impacted this total cost of care more? Why are we still continuing to see such a catastrophic growth in healthcare expenditure? And what do we do? So
Yeah. So, Dana, I have some thoughts on what you bring up. I'm going to make a quick
Please, you
sidebar
do.
on
People have
Alex.
heard me talk about this.
So Alex, look, I could be wrong on this. I could be totally wrong on this, but I don't think value-based care is going to do anything while you have the nutrition issues we have. Smoking has gotten a lot better. And I'm not saying anything pro or anti drinking, but like when you go to a football game and you got the Miller Lite can and the bottle long neck and they're racing on the field, like we're promoting things that alcohol objectively does not make you healthier, right? I mean, even they're debunking the whole thing about wine making your arterial disease better. I
yeah.
think that's even debunked. Right? There's nothing good health-wise from alcohol, and now you're seeing this movement again. So our society, like our poorest, our most underserved society, is subsisting on the worst nutrition. So those costs of care, yes, end of life, you can talk about that as a separate thing, right? But you look at chronic renal disease, liver disease, all the cardiometabolic disease, that's being driven from just an unhealthy society, right? That's really what, if you look at anybody who's lost a lot of weight, they'll tell you their lab's normalized. And if your A1C is in the 5 range, it's probably healthier than someone whose A1C is in the 10 range, and your weight comes down, it follows. So I think the cost of healthcare in our country cannot be looked at from a lens of value-based care without actually focusing on the drivers of cost, which are say what you want about the Maha movement, at least we're talking about it, right? So I think that's that. And I could be wrong, but I've always get such a reaction where it says cost is going up. That means our medicine is bad or care is bad. You can't combat bad nutrition, bad lifestyle, sedentary lifestyles. So another side point. So when COVID hit, Protera was starting to get going, and I figured, I was like, oh, there's gonna be a lot less MSK burden because people are not moving. They're sitting at a desk all day. I didn't know. I'm a surgeon. I'm in clinic or I'm in OR. I don't sit down. And then when I started to be more sedentary, doing more of this work, I saw that actually it's actually more impairment, more disease, MSK conditions. So I think our lifestyle is atrocious, and we need to figure out ways to fix that, to bend that cost curve. And then Dana, to your point about PTs getting involved in value-based care, I would say this: the job of a largely fee-for-service physical therapist, orthopedic surgeon, is to really act in your financial incentives, is to do as much volume as you can with an eye on quality. But once you've seen me in the office as an orthopedic surgeon, you cannot expect me to do value-based care as an individual. But you have to change the incentive system. So let's take out the small practices because that's going to be hard. But let's take a large PT practice, a large chain. What can they do? Well, they can go to the carriers. They can do more direct contracts with an employer. They can say, look, and they're doing that. Like a lot of them are doing that. Say, look, don't send your physical therapy out to the fee-for-service at large, ethos. Come to us. We have scorecards in place where we minimize the visits and maximize the outcomes to save you money. And then we take the expected cost you would pay, and then we bonus our staff that, or we work out shared savings. And I think that's where it comes down to. And some of the payers, and you guys can tell me if this is true or not, I had always heard that a lot of the payers are already making some of these narrow networks. If PT A ends up costing this much for low back pain and PTB costs this much, they're going to prioritize the referrals to that or the payment or the incentives to that other physical PTB. And I had heard this is happening longstanding, but you guys can tell me if it's not. But that is a form of value-based care, kind of, if your per patient treatment costs are lower than your neighbors.
Yeah, as long so just to quickly react, because I think when therapists hear, well, we just have to spend less, and then who benefits from that? It has to be a structure, and I agree, it's totally possible. I don't know how much therapists are doing it, but to combine, here's how we lower your total cost of care, and even things like keeping in touch with patients beyond the point of, quote, discharge or transition off of regular care, how your complete intervention impacts their total cost of care, knowing that the expenditures in the MSK space, once you quote, discharge, but transition them off, oftentimes we lose track of them, and then they end up getting interventions that were avoidable had they continued, if they have a problem, to come back and re-engage with therapy. So being able to work on and have a meaningful conversation with the right folks at a payer to say, if we accomplish these things and we can show you in the data how we are able to do that, then this is, we to get to make up for this lower volume and to acknowledge the fact that we're saving you from your total dollars, then you're giving a portion of that savings to us. And that there is a little bit of complexity in that, where you have to have someone in the practice own that, believe in it, and convince their partners, like, this is something viable that we should pursue. I just want to hop back quickly. I agree on a lot of the things about our society on the value-based care, like why hasn't it progressed? It really is about these very long-standing cultural, beliefs of the public and by providers, where we do have a system where we have specialists, but the way we pay specialists and their ability to do volumes of services at higher paying codes, if you look at health expenditures, it's not because primary care or physical therapists or behavioral health is spending so much. It's because even when we make cuts to the conversion factor that, that's multiplied by the relative value units, if you're not time-based, you can do more. And so, right, it's not a criticism of specialists. It's to say, this is how we've set things up. We've set it up so you have to figure out how to survive in your career, and the structures are not helping where we need help to improve care. So this is why you're seeing over the last couple of years an attempt by CM to send more dollars to primary care, to shift some of the RVU weight to primary care, to add more codes and fee-for-service for things like care coordination and community health integration and care navigation, things that primary care is not paid for. And the problem with therapy is we're not part of that conversation, where our voices need to be out there saying, we do all kinds of work we're not being paid for. It is very similar to primary care, and we need to consider this, because the best thing you've said, and you've said a lot of great things in this hour, it's not viable. Like, we are not going to have a profession left. We can't have people graduating with doctoral degrees making less than registered nurses. I went on the website of where I used to work, wonderful health system. They are paying RNs the same as they're paying DPTs. It's the exact same salary. Why would anybody go into this profession?
Yeah, and it's pretty wild, and I think that look, as a value-based organization, like, it's your job to figure out how to get people to the right place. If you in our podcast, it was episode 2 with Charles Day, Dr. Day. We talked about this kind of shift in revenue, these RVU values. So orthopedics, we're going down in our per RVU basis, and what's happening is the government and payers are saying, okay, look, the payment is no longer going to be procedural based. There's going to be a pot for outcomes, a pot for quality, a pot for value-based care. And if you're an orthopod, if you want to just keep working more, like, at the end of the day, we're factory workers, right? We make widgets and those are surgeries. And if the price of the widget's going down, you have to work more, or you can sell a different widget, which is value-based care.
Oh, I
And
love
the other
that.
thing is, I'll say this.
Great framing.
The saddest realization when you see new surgeons come out is that when they do realize that we're all factory workers. Like, it is just a very high paid, specialized factory workers. But it's not like if I stop working next week in my clinical role, I'm going to get paid. No, if I don't make the widgets, we're not going to get paid. The other thing, and this will kind of marry both points with yours and Alex's, is you have this situation which is so insane to me. We lament our rising costs. We know that preventative care would fix it. More, FQHC, like more investment in the communities. We could just pay more to primary care. If primary care doctors made $1 million a year, if physical therapists made 5x what they're making now, and we know it's preventative, what do you think is going to happen? There's going to be more preventative care. We won't have a PCP
Exactly.
shortage.
Yeah.
And it's kind of crazy, but like we could literally just change the reimbursement rates for preventative care. If you look at the time-based billing, a primary care doc and the complexity of billing, like a primary care doc can spend an hour and orthodoc can spend a fraction of that. They bill the same, level 4, level 5. Like we could actually fix this, and I just have no idea why we don't, but we could easily fix a lot of this.
We're
So,
thinking way too hard, I think,
I know,
it's
I
a
know.
very good point.
It's crazy
But
talk.
things have to be incremental.
no, I mean, it's right on. And you're absolutely right. We really are all factory workers. And it's just a matter of Henry Ford coming in and putting an assembly line in and then standardizing the process, right? Like then you can get
It's
Model
already
Ts
happened in
pumped
healthcare.
out, right?
It's already happened.
Yeah, it is, right? So what do you think of it this way? So one of the interesting facts about you that is you're a team physician for Detroit Lions, which is pretty awesome. And average salary of an NFL player is what, like $2.8 million, right? Probably more. So when you're approaching a high valued asset, how do you approach a healthcare delivery in that domain compared to when you have Alice Smith Albuquerque, right? Who's getting healthcare, whose net worth is minus $45,000 in credit card debt.
Yeah.
Um, and the reason for saying that, so working with the U.S. military and the Department of Defense, there's a cost structure, what an average soldier costs compared to a specialist cost, compared to a specialist operator cost. And so a specialist operator costs U.S. government like millions of dollars. So the cost of maintenance is going to be proportionate to that. Are we not adjusting the fee schedule to be proportionate to the individual cost to the government? Right? It sounds uncouth. But in reality is we're already doing it. Insurance companies are already valuing us like that. We're units. Like just like you were and I am a factory worker in a clinic. People are factory workers in their lives, right? Oh, you're born, you live, and you die. In between that 84-year span, there's a cost that you accrue, and then there is a diminishing cost that you start to extract. So what gives to our healthcare system to continue to provide the same type of healthcare utilization parameters to someone who has X cost to Y cost, right? And I know it's really troublesome thing to say, but that's
Yeah.
the reality of life.
Well, I think one problem we have is that, we don't have a free market in healthcare. And I'm not saying the grass is green. I don't know if I can say that either, but you have rates that are set by the federal government, CMS, and everything's pegged to those rates. You have Medicare rate, CMS, and you have Medicaid, ACA, and the commercial plans are be based a percentage of that government rate. So what happens is this. Let's look at Canada, right? Let's say you have all these people on wait list. Many of them are coming to the U.S. paying cash for surgeries because they can't get it up in Canada. They can't get that care there. So that's kind of a little bit of a free market. They're coming to pay cash for those services. But I think the problem is that we haven't figured out a way to, like, a free market also doesn't work, right? Because you marginalize a lot, and healthcare is many considered a right, an access right. So we haven't figured out yet where you can have a baseline level of care. And that's what all these programs, Medicaid, ACA, have been trying to fix, a baseline level of care, preventative, basic specialty care, and then you can, pay up for more specialized care or faster care for elective conditions. We kind of do it, but largely the insurance is still pegged. You could have billionaires on straight Medicare, and they'll wonder why they don't get seen sooner, right? It's also, as providers, we can't accept in a lot of places, at least my understanding, you can't accept hybrid billing. I can't put a shingle on my door saying, if you want a rotator cuff repair sooner, just pay me $3,000 more. Like, that's not legal, right? So we can't even, people who need it, who have circumstances, we're dealing with a lot of the copay deductible system. The deductible system is insane in many ways because, people coming to see me in clinic and they need surgery before the end of the year. They've met their deductible. That's actually driving a lot of utilization. It's like, oh, sure, let's just do surgery now because you've hit your deductible. That doesn't make a lot of sense either because that's not a clinical reason. But it's all these logistical reasons, and pro sports is its own whole different domain. The rules don't always apply there either. But yeah, I guess the polite way of saying it, a lot of opportunity for improvement.
Like UK, so England did a bunch of really good studies about this exact approach, the wait and see approach and the cost versus outcome ratio, right? And so the wait and see and delaying procedures did result in a higher conversion to cash business, but also resulted in a higher abstinence from these procedures because at a certain point, people are like, oh, I'm feeling a little better. Maybe I shouldn't get this knee replacement. Continue to live my life. Because I think the way we consume healthcare is also based on availability of resources and our ability to afford these resources, not based on a clinical need. But we, like, even with the best intentions, we still will provide care when somebody shows up at the door with a high paying insurance. I know I will, as much as I don't want to admit it. If I have a patient coming in with a nice Blue Cross plan and it's the end of the month and I have an open time slide in my schedule, I'm like, man, why don't we take care of your posture? So
Yeah, I
Problem
think,
is, if you have a retinal detachment, you want that done in 24
yeah,
hours, right? So
for
you
sure,
hope there's
for
a
sure.
retina specialist available that can see you.
yeah, it was awesome to talk shop, and I appreciate you guys.
Yeah, dude,
That was
you're
so much
awesome.
fun.
Like, keep kicking ass. Like, I look forward to seeing how quickly you ascend and how quickly you grow because you really are making a difference.
You've been at this, I was going to say, since the Kevin Bozick days, like his original work, right? Weren't you involved in
Yeah.
that all the way back then?
Well, he started mentoring me in 2007. So I called him in 7. I was walking into the cafeteria of the business school and I called him and he took me on. And yeah, so disciple of Kevin and Judy Baumhauer from Rochester and all kinds of other folks that have been, and it's kind of all of our paths are crossing again in this new way. So no, this is super exciting and I can't wait to see how it turns out. And I appreciate you guys.
We
Appreciate you.
appreciate you. Thanks for being our very second physician. This has been awesome.
We can get a bunch more. If you just want, we'll get a bunch more.
No, I say this all the time. We need physician champions for therapy. We need you to help us spread the message because we're not doing it enough ourselves.
Take care, guys.
So that wraps up what I'd call a transformative and necessary conversation with Dr. Eric Makhni. If today's talk about the healthcare factory or the pivot from hands to brains resonated with you, please share this episode with a colleague or clinic owner who is feeling the weight of the current reimbursement model. The best way to support the show and keep these disruptive conversations going is to subscribe and leave us a review on your favorite podcast app. You can find links to Protera Health and more resources from today's episode in the show notes. Thank you for listening and for being part of the movement to future-proof the physical therapy profession. We'll see you in the next episode.